Yeah,
logo. So
yeah,
probably
we are live
we are live.
on YouTube.
Okay, it's about to start. I will give you the link in a minute.
Yes.
I'm sending it in the chat of the Zoom. Okay.
Okay.
En YouTube en directo, ¿eh?
Okay.
Perfecto, sí, sí.
Me ha llegado a mí un aviso.
Okay.
Okay.
So
Ahí tenéis el enlace. Do you have the link in the chat, Nicola?
link in the chat.
In the Zoom chat, you have the link if you want to share.
Yes. Right. Okay, but I have. Okay. So in the 2 minutes we can start. In 1 minute.
Okay, so let's. Okay, perfect. Let's silence all of us and stop the video. And in 5 minutes we start. That's fine.
Not
Venga.
far, maybe earlier.
Perfecto.
Okay. 5 minutos y nos vemos.
Venga, hasta ahora. Gracias, Álvaro.
Nada.
Desconéctate y ya te aviso yo, ¿vale? Cualquier incidencia.
Perfecto.
Venga, ponte a lo tuyo. Mil gracias.
I think
Chao.
5 minutes, Nicola. 5 minutes and we start, okay?
Okay.
Hey guys,
Yes.
hello, are we ready?
Yes.
Nicola?
Sorry. Yes, I will let our participants to contact to
Okay.
our meeting. And
Okay.
yes,
I still have 2 more waiting here.
we are ready.
Okay.
Okay.
Hello all.
Hi. So maybe I will start in Ukrainian and will show some video from my chief because he couldn't attend
Estoy haciendo doble conmigo aquí,
the
perdón.
invitation
A
video.
ver cómo bajo aquí el volumen.
Okay, Nicole, I think that's fine to welcome.
Okay. Так. Jose, I will start in Ukrainian. Okay? Don't mind.
Okay.
Шановні учасники, добрий день. Ми раді вас вітати на іспансько-українському нейроваскулярному мітингу, який організований Центром ендоваскулярної нейрорентгенохірургії і університетською лікарнею міста Аліканте. На превеликий жаль, директор нашого курсу Дмитро Вікторович Щеглов не міг взяти участь, бо в нього термінове засідання в Міністерстві охорони здоров'я, але він просив передати найщиріші вітання і продемонструвати вам коротеньке відео.
Колеги, я радий всіх привітати. І перш за все, наша зустріч відбувається завдяки нашим друзям. Друзям, які спромоглися і вирішили разом з нами проводити так звану, як ми назвали, Україно-іспанську школу по нейробіології, яка буде орієнтована на лікування гострої ішемічного інсульту, саме надзвичайних складних ситуацій. І дуже дякую Хосе Ігнасію і Хосе Карлосу за те, що вони очолюють цю школу і проводять разом з нами і для всіх наших бажаючих лікарів, які займаються чи хочуть займатися цією справою, яка дуже актуальна в Україні на сьогодні, і я думаю, що вона буде розвиватися. Дякую всім. Це в нас така перша зустріч. Ми плануємо на протязі року, серпня 23-го року, по червень 23-го року, проводити декілька зустрічей в відкритому форматі і просимо всіх бажаючих залишитися до нас. Думаю, що все всім сподобається. Дякую.
It was, yes, Jose, it was a short invitation of our chief, Professor Dmitro Щеглов, and probably we can, Jose, can you hear us?
Yes, I can hear you, but it will be Jose Ignacio to start the meeting with you.
Okay, Jose Ignacio.
Okay, everybody is Jose here.
I just, please, I just suggest that everybody is muted because people are not muted.
I'm working on it.
No, everyone is muted.
Yes.
Can we continue?
Yeah.
Oh, yes. Okay, I was muted by Rayon. I don't know how he do it, but he silenced my micro. Okay, I am Jose Gallego. You saw everybody here is Jose Gallego, Jose Carlos. I am actually the head of the department in interventional neuroradiology. nevertheless, is Rayon, Dr. Rayon, that has worked so much with you to try to build a bridge, to have a link with you, helping in what we can. And we will start with this educational neurovascular school or something like this. I think it's a good way to start. We are very excited with these meetings. And today, I think we saw it as a pilot program just to see how it works and how to do those 2 language or 3 language exchange, problems with the translations and so on. But it will start probably in September, if I am if it is correct. And we want to do it monthly. We will start today with the stroke cases, but perhaps next event could also take place with bleeding cases or with hemorrhagic cases. And let's play the music. Let's give Dr. Rayon the micro and the possibility to explain us what he has prepared for this first session. Let's start.
Okay, can you hear me? Yeah.
Yeah.
Yes, Jose.
Yeah, so let's do something here. So thank you all for participating, of course. Let's see how this experiment today works, hopefully well. So I have to allow myself to share screen. Yes. Okay, I think that should work. Can you see my presentation now? Is it okay?
Yes.
Okay, perfect. So here. Okay, so in this case, I'm going to start talking about tandem occlusion because apparently you were interested on this topic. So the general presentation would be what the issues, the difficulties we find when we are in front of tandem occlusion. First part would be how to pass the carotid occlusion. And that how-to for us, it's very personal. It depends very much on the style of the operator and a bit of the case. But we can go from trying to go through with a micro wire and a micro catheter and then intermediate catheter to being quite aggressive with a 0035 wire or even a stiff wire to be able to get into the internal carotid artery and from there try to open it by angioplasty or whatever is necessary. One big debate on tandem occlusion is if we should open carotid first and treat carotid first and then go into the brain or the opposite. In our center, we always work on distal to proximal. So we look for the way to go through the carotid. We go into the intracranial occlusion, which we find is priority to get some flow. We open it and then we think about carotid. Then about the thrombectomy itself, what makes it a bit more difficult is like when you have an occlusion, it might be usually because they have an unstable plaque already, which has been dissected and then occluded, or also while thrombectomy to go through the occlusion, you may create that dissection just going through with your wire, or also when you open it with a balloon, you can make the plaque to dissect and then to have some intima going upwards, which might make it a bit more difficult. Then about what to do the carotid, once it's open, once we have been able to go intracranially to treat, then we have to decide if we want to stent or not to stent. Those things I wrote there, aspects, etiology, NHS, CTP, or antiplatelet will be key things to think about, but I will discuss this during the case. So in our case, that's a 83 years old woman. She is only hypertensive, no other history, no other medication, and a smoker, active smoker. Ranking is 0, so she was doing a normal life, despite she was 83 years old. So 3rd of June, she, in a moment, nobody saw. Family saw her at 11 o'clock at night, but we don't know when the symptoms started. She appears with total left syndrome, which was based on hemiplegia and aphasia. It's 22 points NHSS. When we talked to the family, they report she had some symptoms the week before. Like before that, she already had some language impairment intermittently, and also vision impairment. So that fits quite well with the carotid, which was being dysfunctional and finally closed that day. Because there's no time to know when those symptoms started. We have no RTPA, we have no endovenous treatment, and this would be the case. And now I have to look for okay, here I think I can use this. Okay, so here we have the CT, and we consider this to be an aspect 6. We remove points. We consider it was established infarct already on M3 here, and also those posterior lobes here. And we had some doubts about the insula. And I want to take a look to the basal ganglia because I consider this to be okay, but then on review it's not that much okay. But at the moment we consider it to be okay. About the occlusion itself, we can see in CT, you can see here there's an hyperdensity already on the distal carotid, and also ACM. And also it's arriving into M2, okay? So at that moment, we consider we have a aspect 6 patient, 83 years old, with a carotid T or distal carotid occlusion. Then we do CTP. Sorry, I can't pass the up now. We do CTP. And okay, and we see a few things. One of the first things we say, I don't know, do you see my pointer here?
Yes, Jose, we can see your point.
Okay, so perfect. So one of the first things we see is there's a pulmonary mass on this woman who nobody knew about, but we knew she was an active smoker, so we suspect this is a tumor. Also, we start seeing a diffuse atheromatosis on the aortic arc over there and over there. And then when we look at the carotid bulb, we see the right side is open but has quite a few of plaque, and here on the left side, it looks like it's some contrast going through, so a critical stenosis probably, and with a big plaque also here. Also on CT, what we take a look to is we see here there's no ophthalmic flow coming from here, so we suppose there's a thrombus already in the distal carotid. Also, we see A1 is cut, so we are considering this already a carotid T. And also we see there's quite a few collaterals on the left side. Unfortunately, we don't have CTP. And you'll see why we consider important to have CTP here. The patient moved or something happened, and we couldn't have the images. We would have used them to know if anterior territory was insufficient or not, and also to be able with aspects to evaluate further if there was an infarct, established infarct on this area. So at the moment we are considering, we have an 83 years old, aspect 6, carotid T occlusion. We don't pay attention to the tumor because that's something unknown, and that's our protocol. So when we go into the DSA, what we see when we do an injection in the left common carotid artery is what look in the CTA like a critical occlusion. Here looks like an occlusion, total occlusion. Okay, so we try to go through with a 0.035, and in intermediate we weren't able, so we finally passed with a 0.14 microwire, microcatheter, and over it an intermediate catheter. We usually go for aspiration as a first attempt. In this case, as we saw, it was a very long thrombus. We considered it was better to go with aspiration and retriever. So at the moment, we just passed the carotid with this, with intermediate catheter and the microwire and catheter. So we go up for the occlusion here, and we see two things there. That have to be taken into account for us, which is we see partial thrombus in the distal carotid. What it seemed in CT again, or it was before a carotid T, is not a carotid T anymore, but we see partial thrombus in the distal carotid, and then we have an M1 occlusion. That makes us decide to go for aspiration and retriever. So we will aspirate here till here, so to protect A1 from the thrombus going inside, and we will use an stent retriever to open here. So here you have the image, like the intermediate catheter goes distal into the internal carotid artery, and the stent retriever is on the ACM. We remove the stent retriever, and as we saw, it was blocked, or both the stent retriever and intermediate. We do the pinching technique, which means we put the stent retriever partially inside of the intermediate catheter, and then we bring all together. And as you can see, well, here, I'm afraid, that will be the final result intracranially, which is everything's open with some distal lack of perfusion here. So now when we have opened intracranially, now is when we start thinking about the carotid occlusion. So we look at this carotid, what it was an occlusion, we went through with the intermediate catheter, so it's a bit open, and we discussed with the neurologist, which is on the angio room, what to do, because there are reasons not to do further treatment, and there are reasons to do further treatment. Not to do is we have a low aspects. It's not a low aspects for stroke, but it might be a low aspects to give antiplatelet treatment. We have 6 aspects. Then we have no CTP, so that's 2 things. We don't know exactly which regions are infarcted already, so we don't know how many regions are susceptible to bleed if we use antiplatelets. And on the other hand, we don't know how much we need to open, because ACM is open, but the blood is arriving through the anterior communicating artery. So in some cases, we could just left this carotid to close. But we don't know if also the anterior territory may be on risk. And finally, there's one thing we have to look here in this image. If you look, we did an injection from internal carotid artery, and we see something which is lenticular striates. They have arterial flow going fast, and so fast that we see already venous drainage on the arterial phase. For us, this is a sign of this basal ganglia that we didn't appreciate that much on CT, that might be infarcted, okay? Because that's the reason to have that fast pass of the contrast to the venous, because there's an infarction, so there's no stop of the flow on the basal ganglia. So we consider aspects could be a bit bigger than we thought. In favor of opening, is we try to go through with a filter, we can't, and we see along a few minutes that the artery is closing, so it's going to close, and we know that. We have no other medication, so no RTPA, no anticoagulation, nothing previous. And also we have here with the protocol we use is to stent only using ingesprine, which is aspirin, 450 milligrams endovenous. And then we do a control CT on 12 hours. If everything is fine, we will play with the double antiplatelets, okay? So finally, in the discussion with neurology, it was a really limited case, but we decided to proceed. So we do 4 per 40 angioplasty here. We open a little bit, so to be able to pass the stent, we put the stent here, and we see there's a dissection, there's a lesion on the wall of the carotid, as we said it might happen. And then we do post dilatation, and we recover the whole internal artery. We see the plaque, it also affects external. So this will be the final result. Everything is open with in the carotid and intracranially with this filling missing on the distal. What we use is general anesthesia, 9F on the groin, Neuromax as a support catheter, Red 68 to go up intracranially, or in this case, distal carotid. And the stent we used, it was a 6 per 25 treble, because most of the thrombus was on M1. Micros, and those were the balloon pre and post collocation of this stent, implantation of the stent. And this is the follow-up. After the procedure, the patient passed from 22 to 15 NHSS points. In 12 hours, he was already in 6 points. And as you see here, it looked like it might have bled. You have to be very careful here, because there are some signs that can help us think it's not that much bleeding, as we see the anatomical structure of the lenticular here. If we take care, we see there's no subarac here. It's more like the cortical region, which is hyperdense. That might help you to differentiate bleeding from not bleeding. In our case, we have some help because we have this dual energy CT. And as you can see, this hyperdensity here is hypodensity. And that tell us it's more of a contrast extravasation than bleeding. So we could start double antiplatelet already in 12 hours. And a few days later, 10 days later, these patients go home with these 6 points, which means facial nerve palsy, dysarthria, and some loss of mobility in the inferior, in the right leg. So as takeaway message is every patient you will have to differentiate one by one and work on team with the colleagues we have around anesthesiology and neurology to make considerations, and then make always a benefit risk balance, taking into account aspects, comorbidity, CTP if available, it helps a lot, medication, and also team experience to do something. Distal proximal, that's a discussion I'm not going into. Yeah, the antiplatelet regime, it changes quite a lot depending on centers. We use this Ingisprin, then 12 hours double antiplatelet, and it's working fine so far, but there are some other possibilities. And maybe open to discussion is what to do when you have an isolated carotid occlusion with a high NHS score. I'm sorry it was a bit too long. Thank you very much.
Thank you for your interesting presentation. And we have a question. And how do you consider the best strategy for isolated carotid occlusion?
I really don't know. We really do it in a case-by-case basis. I had the situation not treating isolated occlusion because of the risk of emboli in smaller vessels that we are not able to treat, and unfortunately that patient died. But also the opposite experience is possible. You may try to open not that high clinical deficit or improving clinical deficit with collaterals and everything, and then create like a multi-thrombus situation, what might be worse. So I wouldn't be able to give an answer.
And how do you think, should we use CTP for every isolated carotid occlusion, or how do you think?
I think it helps. In our center, we have this, which is for every stroke we have in the CT room, because sometimes the stroke arise from different region or hospital. So if they have imaging and we can bring them to the angio room directly, and we really win some time, we won't go through CTP. But if the patient is in CT room, we will always do CT, CTP, CTA. So that makes us to be used to reporting really fast CTP, also radiographers to be used to it, and nurses. So we always do CTP. As I said, for a tandem occlusion, it might be useful to differentiate, to support what aspects we have. We have like double information on the established infarct region, but also to give us information about anterior circulation. In case of isolated carotid artery, I think it would be more based on the clinical evolution. Like if we see it's a permanent deficit, it's like a high deficit, 22, 25 points, and it's not improving at all, we would consider to go for it maybe sometimes. CTP, if affecting also anterior circulation, or CTA, we see ACOM is not good, that might be one more point in favor of treating. But as I say, this is a one-by-one patient-based decision, I think.
And we imagine such scenario, for example, patient with low NHSS and Tmax more than 10. How do you think? Should we open the vessel?
I wouldn't. I wouldn't be able to answer to this Tmax specific range, because we don't usually take a look that closely to the numbers, but more to the general picture. But NHS 10, depending on which points is this. So if it's a facial palsy, dysarthria, but not aphasia, not a huge motor deficit, like more sensitive, you know, it really depends on the case. But 10 points is not that much. We would, because we will discuss this with neurology, and we will have probably a long discussion, and probably also discuss with the patient or family themselves. If it's 10 points, we probably can talk with the patient. So we probably will discuss with him or her what to do.
Okay, thank you, Jose. Thank you, and
thank you very much.
And our last question is: how often do you use balloon guiding catheter?
So for us here, we don't use it that much, because as we go with aspiration as a first approach, with most of the balloon guide catheters, or they are too big. So we use a 9F on the groin, but it's only because we are giving the blood pressure information to the anesthesiology, but we use 8F support catheter. So some of them, they are too big. Some of them, they are 8F, but they won't be able to go through with the intermediate catheter when it's a 68 or bigger. So now we have a new possibility. We are trying this catheter, which is called Walrus, which is used in the States already, but it's new for us here in Europe. And this one, it's 8F, but it's a bigger inner lumen. So we are doing the first cases with balloon catheter and aspiration. But till now, it was a bit of incompatibility of doing aspiration as first approach and using a balloon guide catheter. So we are on our first steps with that.
Thank you.
Thank you very much.
Creo que no te entiendo.
Are you able to share your screen, Mikola?
Yes.
Okay, perfect.
Доброго вечора. Мене звуть Станіслав. Я нейрохірург, інтервенційний нейрорадіолог, Центр ендоваскулярної нейрорентгенхірургії Київ. Я хочу до вашої уваги представити 3 кейси пацієнтів з гострим ішемічним інсультом внаслідок оклюзії великої церебральної артерії. Перший пацієнт, 73 роки, був доставлений к нам в центр о 22:40, 30.05. Початок інсульту о 9 ранку цього ж дня. На момент поступлення в неврологічному статусі по шкалі Комглазго 15 балів, лівосторонній геміпарез і парез 7-ї пари зліва. Чутливі розлади на стороні ураження. По НХСС 8 балів, тиск 150 на 80, регулярний синусовий ритм, глюкоза 4. Із особливостей він приймав варфарин і міжнародне співвідношення 2,5 і креатинин 91. І також цукрового діабету не мав, ліпідограма загальний холестерин 3,3. І особливостей 2017 рік, це за 2 роки до поступлення до нас, ще була протезування артального клапану. Ініціальна КТ, яка була зроблена під час госпіталізації, а це через 25,5 годин від початку інсульту, ми побачили аспект 8, лише 2 вогнища в підкіркових ядрах ми бачимо вказано. І за даними КТ-ангіографії, ознаки стенозу середньомозкової артерії. Саме стенозу артерія прохідна, нам дали таку інформацію рентгенологи. І саме через це ми вирішили в цей день, це був тільки початок 19 рік, тільки рік був після обстежень досліджень Diffuse Down. Ми ще не мали можливості проведення КТ-перфузії, і ми прийняли рішення, що критичний стеноз ми будемо стентувати на ранок. НХСС у нас 8, чому? Глазго 15, тільки стеноз без ознак тромбів на рівні стенозу. І міжнародне співвідношення на варфарині 2,5 і час від початку до госпіталізації 13 годин, тому вирішили наступний день провести стентування. Що ми побачили на ангіограмах? І дійсно ми бачимо дефект контрастування проксимального відділу середньомозкової артерії, але так, щоб це було схоже на класичний стеноз, і це вже одразу звернуло увагу, нібито ні. Таке враження, що тут формування тромбу йде на рівні нібито стенозу. Передня мозкова прохідна. З іншої сторони ми подивилися, як компенсація басейну передньої. Ми бачимо добре виражену компенсацію басейну правої передньої мозкової артерії. Після цього ми вирішили все ж таки провести імплантацію стента. Але коли ми почали дивитися на ангіограму вже після того, як повернулися в правий каротидний басейн, ми бачимо, що розповсюдження дефекту контрастування відбувається на внутрішню сонну артерію, тобто йде прогресивно на очах майже утворення тромбу на рівні нібито стенозу середньомозкової артерії. Для того, щоб завести туди, імплантувати стент, ми використали балонний гайд-катетер Септор С і аспіраційний катетер Софія 6 Френч. Софію підвели безпосередньо до місця порушення прохідності середньомозкової артерії, а Септор С, ось його мітки, розташували на рівні тромбозу. Вирішили спочатку провести ангіопластику з одночасною аспірацією, щоб унеможливити дистальну міграцію тромбів в судинне русло. Але на наше здивування, після того, як ми провели пластику і аспірацію, ми побачили повне відновлення прохідності середньомозкової артерії без будь-яких ознак стенозу. Тобто, насправді, чи був тут стеноз, скоріш за все, ні, це був частково прохідний тромб на цьому рівні. З першого пасу нам вдалося відновити протягом 24 годин. У нас відновлення і тільки 3 було, і НХСС регресувало до 2. І на 4-й день пацієнт був виписаний з центру, 0 по НХСС, і на 4-й день і на 90-й день після лікування по МРС 0. Тобто на сьогодні, якщо б ми стикнулися з подібною ситуацією, то ми б не відтерміновували проведення операції, а одразу пішли б, зробили КТ-перфузію, подивилися, що це частково прохідний тромб і видали його. Наступне спостереження, пацієнт 52 роки. Пацієнт 52 роки, доставлений в центр о 14:45, а захворів він 7.07 о 18:00. 23 бали за НХСС, цукровий гіпертонік, цукровий діабет, другий тип. Об'єм ядра за КТ-перфузією 24,6 см кубічних і час до пункції 1255 хвилин. Що ми бачимо на ініціальній КТ? Аспект 5, велика зона ураження. По КТ-ангіо бачимо порушення прохідності середньомозкової артерії, тромбоз внутрішньої сонної артерії, тандемна оклюзія, але в CBV, яке відповідає за ядро, ми бачимо досить невелике ядро. це flow і велика зона пенумбри. Ми прийняли це, пацієнт відповідав нам критеріям DAM, місматч між балами за NHSS і ядром, вік менше 80 років, тобто ми прийняли рішення про проведення реперфузії. Спочатку тут складно знайти було місце входу, де формується внутрішньосонна артерія. Нам вдалося мікропровідником це пройти. Балонна ангіопластика. Бачимо вхід артерії. Після цього зайшли операційним катетером вище місце стенозу, відновили прохідність. До речі, кальоза маргінальна артерія – це, скоріш за все, під час проходження тромбу дистальна міграція, але з непоганою компенсацією. Відновили прохідність середньомозкової артерії, комбінована техніка сейв. Після повного відновлення прохідності середньомозкової артерії передню ми вирішили не чіпати, адже вона непогано була компенсована. Бокова проекція. Лише дистальні гілочки трошки страждають, ось тут видно. Після введення 750 мг целізіна внутрішньовенно через 25 хвилин ми проводили ангіопластику зі стентуванням критичного стенозу внутрішньої сонної артерії, імплантація волстенту, піздилатація, відновлення прохідності внутрішньої сонної артерії. На момент виписки від нас регрес NHSS з 23 до 15, реперфузія 2С, через 16 днів NHSS 7 і МРС регресували до 2. Це контрольне обстеження після проведення, зберігається таке зона ураження, але формування нового вогнища в басейні передньомозкової артерії, стенд прохідний, середньомозкова прохідна, все норма. І це пацієнт через 2 тижні після проведення операції з реабілітологом вже пересувається. Ну, на цьому дозвольте все, 2 кейси, третій не встигаю. Дякую.
Jose. Jose.
Yes, hi, yeah.
Okay.
Sorry for our Ukrainian language, as we agreed that we will have a subtitle.
Yeah.
So on our recorded video, we will have much more information and can make some writing discussion. But nevertheless, if you have some question about these cases,
to be honest, I wasn't able to follow very well because of the language, but I got it's an under 80 years old patient, and that the volume is agreeing with diffuse or down studies. So yeah, I in general what I saw and partially understand, there's no question, you know. I can say that our clinical practice, it goes a bit farther at the moment. Like we are not considering volume that in that detailed fashion. Like when we see we have like more than 50-60% of the territory we can save, we usually go for it. It's a bit farther than guidelines, but we feel it's safe, depending also on the regions which are affected. You know, if we see we can save critical territory, cortical territory, and there's a big amount, because some works they published, they say like opening, because before we thought that opening a vessel could increase the risk of bleeding, but this is under discussion now. And what we are seeing, it's probably is better to open than leave it closed, even if the volume of tissue is bigger than what they publish in diffuse and down. But overall, yeah, very nice case. Thank you.
So we can like cross our part, and we can now go to the last case.
Okay. I'm sorry, I will have to do something, I'm afraid, because our colleague Antonio Sagredo, Dr. Sagredo, is on the OR at the moment. We had a crazy morning today. We have two Sabrak, and then we have an elective flow diver and carotid. So it's probably he was supposed to be here, but probably it's getting a bit more complicated in the OR than we expected. So I will do his presentation. I'm sorry, because I'm gonna be knowing the details at the same time as you are. So this is us. That's our team. That's our boss here, and this is us. And well, there's also some trainees around. So what Sagredo had to present, it was, oh sorry, do you have the screen?
Share your screen.
You don't have your screen, sorry. Okay. Okay, now can you see my screen, yeah?
Yes, but we can see the both. Like it's not an usual view.
Okay.
We have two like present slide and the next one.
Okay. So I think I can change that. I think it's here. Let's see. What about this?
Yes, perfect.
Okay, thank you. I'm sorry about this. So this is us. You can see us now, yeah? That's our team with our boss here, and that's crazy people around trying to work every day. Can you see the screen now, yeah?
Yes, Jose.
Okay, so this is a low NHS case. So clinical guidelines, they are also working on the limits. NHS score 6, it's considered to be limit. Here we consider 5 to be important in case of aphasia, especially to make a big difference. So as Antonio writes here, we can choose on trusting best medical treatment, using RTPA, because maybe low NHS it's distal occlusion and it might be useful, or trying to go into mechanical thrombectomy. In this case, we're talking about a 68 years old male, a smoker, and no other cardiovascular risk factors. That's not the common profile. It's those two cases by chance, but usually they have some more issues here too. And he has only language impairment. Okay, so it's 5-6 points. We don't have a time of the symptoms onset. It's 9 and it's 5, facial paralysis and severe motor aphasia. So as on the other case, we usually go under general anesthesia. Our approach is we always do general anesthesia unless neurologist or anesthesiologist or ourselves has a reason not to do general anesthesia. But we generally go with general anesthesia from scratch. So he used the same introducer to give support to anesthesia, same support catheter, and a smaller intermediate catheter for aspiration, just a bit different microcatheter. And in 26 minutes, he gets a TC3. So the case on paper is this basic CT shows us empty occlusion here already, but we confirm on CTA here and here. We can see the crab legs here, showing it's more likely to be a thrombus than an stenosis or anything else. Here we have CTP. As I said, we move based on general approach. We see time is longer here. Also flow seems to be a bit slower, but pretty much conserved. And what we see is there's no infarct on volume. So they decide to go for it. It's an M2, it's a middle M2, so it's not so far for us. It's a medium risk procedure for us. So they go for it with this catheter, Red 62, and they just do one pass and they open. 24 hours, we see maybe there's some insula affectation here. Generally, it's an HS2, and he goes a few days later with no symptoms. He goes home. So takeaway message here would be as before, as every limit cases in general would say, take it in one-to-one basis patient, discuss with other colleagues also on this type of situation, try to talk with the patient, explain to family members. In this case, I think we talk with the family to explain like this is, he has no somatic symptoms, we are outside of the guidelines a little bit, but we consider we can get a good result, and they agreed to go forward. And well, Sagredo's perspective, and me too, ours too, I would say, in the unit is we're going to do more and more low NHS, but it might change. Is we have some different cases, so it's very different to have NHS 5, 8 when we have an M1 occlusion, or have an NHS 5, 8 with an M2, as this case, or when we have like an M3, M4. So each of those cases that they require a different approach. It also can be more conservative or aggressive, depending on the case, the history, and all. But yeah, low NHS is a big umbrella too. So this case would be like the intermediate situation, which is a more or less proximal M2, which feels safe for us. Some other cases, it might take some more thinking for us to go through. As Antonio says, that industry here is very important because, well, this catheter, for instance, but some others, that they help us go further on the brain and in a quite safe way. And that would be it, I think. Hello, Nicola.
Yes, Jose.
Cool.
And thank you once more for such interesting cases. And I have a question. For example, how do you manage a low NHSS with large vessel occlusion, when you consider it for conservative treatment or medical? How do you approach those patients?
It depends very much on the patient. As said, we discussed it. I would put here into consideration how at least 2 or 3 things, how important we consider this M1 to be for the patient in the future, because maybe they have not much symptoms at the moment, but we don't know in 2-5 years time if that AMC would be critical for them to live. Then, which are the symptoms that would be critical too, like aphasia? We consider that's very disabling. If he has 5 points and it's 2 facial, some paresthesias, we might be much more conservative, using RTPA if possible, or just waiting and watching clinical evolution. And yeah, on intermediate cases with an M1, we may make that decision, which is try to look at blood pressure, try to make it lower and see if clinical symptoms improve or not, or improve disability, I mean, or try to move the patient sitting on the bed or even walking sometimes, you know. So we take some time to decide based on those factors. Age, and also like how stable is that clinical evolution. If it's fluctuant, we would consider it's more likely to go for a high NHS in a few hours. And then what we agreed with the neurologist for all these cases which are in the limit and we consider to do conservative is while the patient after, let's say, a couple of hours it goes worse and it suddenly goes to 20 points or something, we would consider this to be the onset time. So we wouldn't do like a 5 NHS, we don't treat, and then in 2 hours it's 20, and we say, oh, from onset it's 10 hours, so we don't go for it. We would consider that clinical worsening, our start point to reevaluate. Probably we will repeat CT, CTA, and then decide.
Okay, thank you. And how do you think about stroke with 0 NHSS?
With
0 NHSS. Like, do you consider it them a stroke? For example, you have a patient with like slight symptom, and you evaluate him like properly according to the whole neuroimaging and reveal M1 occlusion. And what your consideration about those cases?
This is a very critical and fundamental question, and it's so difficult to answer, because on the one side it goes to the basic of medicine, which is first, do not harm and all that. So why would you go into nobody? Why would you put anybody on the situation of a general anesthesia, or we may do with local, or in this case, of course, but when there's not a clinical event to justify? So that would go really like into a philosophical question a bit. On the other hand of this, with the progression of mechanical thrombectomy and with the practice, when we decide to treat or not to treat, what we are doing is this risk benefit. So there are two things there. Like once you have some experience, you can get to do mechanical thrombectomy very safely, like to be very unlikely to have any complications, especially if in a case like this, as you say, you can approach mechanical thrombectomy in many different ways. So if it's a 35 years patient with an M1 and 25 points, of course you may be very aggressive. But if you have an HS0, you can try to do a femoral puncture, navigate, just give one aspiration very unaggressively. If everything is easy to navigate and the procedure is easy, then you go for it. If it doesn't, then you don't. So doing mechanical thrombectomy is not always the same. You can be more or less aggressive. You can assume more or less risks. But again, with zero clinical or one point clinical situation, we would put into consideration what we said before. What's the evolution? Is it fluctuating or not fluctuating? How ugly is CT and CTA? Even sometimes we use intracranial ultrasound to have like a view of functionally how is it working, and collaterals, of course.
Oh, okay, Jose, thank you. And probably our program is finished, and we can congratulate everyone who organized this event, this meeting, and we can invite the chief of your department.
He's on the OR at the moment. Sorry.
And we want to thank him
Sure.
and for his support, and to support not only our event but the whole neurological society in Ukraine during these hard times. And we are very happy to have all of you with us during during the war, and I hope that our pilot event will have succeed, and we can go forward and achieve some good results with our discussion, as such discussion during our survey was considered very important for Ukrainian specialists all over the country, and we want to do our best to help them. And if you want to add something, you're very welcome.
Yeah, I would like to congratulate you, because this has been bilaterally for here. We've been talking for quite a long time since we met by chance in a rotation, And yeah, this I'm very happy with the result today for a test. It's perfect. I want to thank also Dr. Kornowski for his participation, and of course I'm grateful to OMC and the foundation for giving us a frame to do this, and the technical support, and also, as you say, not only for this academic part, we will hopefully start regularly, monthly, starting in September, but also on the other side of the program, which is a further collaboration in between Spain and Ukraine during those times, and probably further. So yeah, thank you very much. Happy to see you as usual.
Okay, so thank you, Jose Carlos.
Thank you so much.
Ignatius.
I don't know, maybe Sonia wants to say something. Maybe Sonia, please, from ONC.
Well, I'm super happy and excited because this really worked. It's a platform that the only thing I'm wondering now is why didn't we do this before, and why didn't we start this before? It's a form of cooperation that it's super easy. It's not a problem economically, and it's only an addition to all of us. It only has positive aspects. So I'm happy that this really worked, and I'm sure that we can start between the idea we talked between Mykola, Jose Carlos, and I to start like a proper course or a program of sessions from September to June, and we can make it bigger, and we can make it I don't know, like we can grow together and enrich this as long as it becomes a reality, as a real school, as it's called, a really way, a tool for education and for, I don't know, to make us together through this cooperation. So I'm so happy, and I want to thank Jose Carlos and Mykola, because it really started with them, between these two brains. And I encourage you to build more with me, please.
And Sonia, thank you so much that you also support our initiative, and also all your efforts to make this meeting real. And I hope for further communication, cooperation as well. And I will in Ukraine ask our participants to, if they have some question, if you not mind. Шановні учасники, якщо у вас є питання до Хосе Карлоса щодо представлених випадків або до Станіслава Вікторовича, не соромтесь задавати їх в чат. Так, ну.
Yeah, I just wrote our email address in case anyone wants to contact us and do further question. Also, I think maybe a good moment to say this further working with, it might be open to more people. We will try to coordinate and all, but of course we feel privileged that Kyiv has considered us as partners for this. But there's so many people who is able to show and teach so many things, so many times better than us. So we will be trying to get the best people to be able to present the cases for the Ukrainian public in this case, but it's bilateral, of course, that it will be of benefit for us too. So we will talk about this further in the future, but this might be open to more people, and yeah, we'll talk about it in case someone is interested.
Okay, thank you. And on this message, I want to finish our meeting. and to say everybody that we are happy that we can share our experience, and I hope for further communication.
Okay.
Bye-bye.
Thank you very much. Take care, mate.
Thank you all. Bye bye. See you soon.
Bye.